Good afternoon. My name is Tim Poe. I want to welcome you to the UNC Cancer Network RN and Allied Health Lecture today, October 10th, 2017. A few preliminaries before we get started. If you need to reach us for any reason, the quickest way to reach us is always to give us a call. 919-445-1000. That rings everyone's desk phones. Somebody should be able to help you resolve any issues that you may be having. You can also email us, unccn@unc.edu. We'll talk about Poll Everywhere in just a minute. We have all sorts of resources on the web, unccn.org. You can find our upcoming lectures. Almost 200 previous lectures are recorded there. You can find us on Facebook, on Twitter, on YouTube. So, but the web is a great place at the unccn.org to start all of that. All right. We are going to use Poll Everywhere, as we do with all of our lectures. If you've used Poll Everywhere before, you know the drill. If you haven't, here's the way it works. You can do one of two things. You can either go on the web to pollev.com/UNCCN, and then you'll be able to see the questions and respond to them there. Most of the people who use Poll Everywhere, I believe, actually use a phone. It can be a smartphone. It doesn't have to be a smartphone. It just has to have texting capabilities. So you text the numbers 22333, or excuse me, the letters UNCCN to the number 22333. So you're going to go 22333, that's your destination number, and you're going to put in the letters UNCCN. You do that one time, text that, you'll get a text back saying that you've joined the session. You only have to do that once today. After you've done that, then you can respond to the questions. We'll have some different polls, including one that's up on the screen right now, and then at the end it will be open-ended Q&A, and you can text us your questions once we get to that point. So the first one, patients with cancer and depression experience, and then you've got these four different answers. Decreased adherence to cancer treatment, longer hospital stays is B, greater medical costs is C, or D is all of the above. So think about that. Go ahead and get that set up. You can respond to that, and then we'll put that live poll up in just a moment. All right, our presenter today is Kyle Lavin, MD, MPH. Dr. Kyle Lavin is an assistant professor in the Department of Psychiatry at the University of North Carolina School of Medicine. He is board certified in psychiatry and has completed fellowship training in palliative medicine. Dr. Lavin serves as an attending physician in the UNC Palliative Care Program and is also a psychiatry attending physician in the Comprehensive Cancer Support Program. Dr. Lavin's clinical interests are in exploring innovative ways to integrate psychiatry and palliative care, providing excellent psychiatric care in the palliative care population, and supporting patients with mental illness and palliative care needs. All right, we'll bring that up, and we'll go ahead and say welcome to Dr. Lavin. Thanks so much for being here today.
Yeah, appreciate it.
Yeah, so maybe you can start out. We've got our poll up now, so we'll hope that we see some responses. And by the way, for all of our folks who are submitting answers, this is completely anonymous. So go ahead and give it your best guess, and we'll see what you've got here. While we're waiting for those to come in, what led to your interest in blending palliative care and particularly working with oncology patients with psychiatry?
Yeah. So in terms of where my interest started from, I actually, the journey started at the Brain Tumor Center over at Duke. And, so was seeing patients there who had very advanced cancer and was working with them in more of the sort of curative role and thinking about survival. And then ended up coming to medical school with that in my mind as going to medicine and becoming an oncologist. And then had the opportunity to work with Don Rosenstein, who's head of the CCSP here, and he was my master's thesis advisor. And so he taught me about, or allowed me the opportunity to do a master's thesis on the timing of end-of-life discussions for patients with advanced cancer. And through that, I really realized that my interests were not in the oncology and treatment aspects, but more in the psychosocial support and the psychiatric needs for patients with cancer. And so going through psychiatry with the end goal of going to do a palliative care fellowship ended up being what my goal was.
Great. And I know that some of you are familiar with Dr. Rosenstein, either from visiting the facilities here or from previous lectures, and we've had him on multiple times. And always enjoy having him here as well. Okay, so how is our audience doing with the poll question?
Looks pretty good. We can go over some of these specifically later in a little bit more detail, but the correct answer is all of these, that there is both decreased adherence to cancer treatment, longer hospital stays, and greater medical costs for these patients who have depression and cancer.
Okay. All right. Well, looking forward to hearing more. With that, I'll pass the controls over to you, and thank you so much.
Appreciate it. So what I was tasked with today was having a discussion about the title Psychiatric Medications and saying I'm not a prescriber, what do I need to know? And my thoughts and what I want to accomplish today is that I'm hopeful that by the end of the discussion we'll be able to recognize the importance of psychiatric care for patients with advanced cancer, being able to go over some of the ways we diagnose it, the ways that we look at it. Also like to talk about some of the basic psychiatric medications that are used in the treatment of these patients. And then finally, hoping that we'll be able to list some of the common side effects and the drug-drug interactions to be aware of when caring for these patients. My hope is that this will be a practical thing that allows, my understanding is mostly nurses, but other clinicians who interact with cancer patients and spend time at the bedside. So thinking about, obviously not how to prescribe these medications, but to be aware of the different psychiatric conditions and then the things to look for when patients are taking these medications. So I think it's always helpful to have a case in mind when we're thinking about something like this. The case I'd like to start with and have you keep in mind as we go throughout the lecture is about a woman named Miss F. She's a 78-year-old woman with a history of metastatic breast cancer to the bones and the liver. In the past 6 months, she's fractured 2 of her vertebrae and has been hospitalized for a pulmonary embolism. In terms of what her decision-making's been, she's always wanted to be very aggressive with treatment, always interested in pursuing further curative treatment, primarily so that she could continue to care for her daughter, who she has a very strong relationship with. Recently, she started to state that she no longer wants any treatment, no more chemotherapy. And when asked about her symptoms, she complains of uncontrolled pain, poor appetite, and no interests or hobbies or interest in spending time with family. And when asked the simple question, are you depressed? She responds, my future is over. There's nothing good ahead for me. Anyone would be depressed in my circumstances. So we'll come back to that case at the end and have a little bit more discussion. I wanted to can't give the whole story, and I told you a little bit about how my interests evolved, but my hope was to tell a little bit of the story of Psycho-Oncology and where that came from and how closely that overlaps with palliative care. And for those of you who don't know, palliative care is a newer specialty that's evolved in the last probably 10 years or so, and the main focus is to work with patients with serious illness, often in the last 1 to 2 years of their life, and to help with 3 basic things. It's to help with goals of care and decision-making, to help with symptom management, and then to help with the psychosocial aspects and support in terms of spirituality and the holistic care for patients. So there's a huge amount of overlap with that in psycho-oncology. And from psycho-oncology, Dr. Jimmy Holland is the founder of psycho-oncology, and she has established a very robust program up at Sloan Kettering up in New York. And that was around 1970 when we first started thinking about the psychosocial and psychiatric comorbidities of cancer. In 1980, she actually helped found the American Society of Psychosocial and Behavioral Oncology, and as that was becoming more to the forefront of the minds of oncologists, it really created more of an interest not just in treatment and survival, but more in quality of life, the experience of survivorship, and also thinking about symptom control. Then there was the Patient Self-Determination Act that was in the early 1990s, and this was an act that allowed patients to have a little bit more autonomy and control over the care they got. It allowed them to create living wills and decide whether or not there were certain types of treatment or life-sustaining measures that they would not want in certain circumstances. So really shifting more from the paternalistic or parentalistic, as they trained me in Seattle to not use paternalistic, but shifting more from that to the shared decision-making or more patient decision-making. Then there was a large study that was called the Support Study, and it really was the first and what kicked off all of the discussions about decision-making and end of life. And it was a huge trial that looked at patients with a advanced illness. Advanced cancer was one of them, and the types of interventions that they would want if they were to continue to get more sick. And this really started a huge discussion about the way we take care of patients towards the end of life. Jimmy Holland then published the textbook of Psycho-Oncology in the late 1990s, and there were multiple reports from the IOM about how cancer care, rather than focusing just on the treatment and the outcomes, needed to have more of a holistic approach, focus on the survivorship experience, and really think about the whole patient. And then her organization that she founded was transitioned to APOS, which is the American Psychosocial Oncology Society, which is a really wonderful organization that I'm hopeful to go to the meeting this year, but combination of nurses, social workers, chaplains, physicians, pharmacists, who all come together to talk about the psychosocial aspects of cancer. And then most recently with the Commission on Cancer instituting mandatory psychosocial distress screening has really gotten us to an exciting time and is a really fun time to be in both psycho-oncology and palliative medicine. So, why do we care about these patients who have depression? And this is where the first question came from. But patients who have depression experience multiple different things, negative outcomes. They have a worse overall quality of life. They have decreased adherence to cancer treatment, so it's harder to get them to take their medications regularly, harder to get them to take their medications on time. They have significantly longer hospital stays, which results in much longer medical costs, which is an issue both from an administrative perspective and from patient outcome perspectives. They have more frequent requests for physician aid in dying or hastened death, and they also have significantly higher rates of suicide. And overall, it does affect survival as well, and have shorter survival time, especially in liver, breast, and prostate cancer. So here's another question that we have in terms of where the risk factors for patients with depression.
Right. So you can go ahead and answer. And again, I think most of you at this point have joined the poll or found us at that pollev.com/UNCCN online. So you can go ahead and add A, if you think it's older age, head and neck cancer, B, C, no previous history of depression, or D, good social support. So which of the following is a risk factor for depression in cancer patients? All right, thank you all for so quickly responding to this. Glad to see people are jumping in, and
yeah, it's fun to have the real-time interaction.
Mm-hmm. Wait just a few more seconds and give you that time if you haven't already responded. And just to let you know, we'll have one more of these a little bit further on in the just so you can be ready for that. And then if you want to be jotting down your questions, again, you'll be able to text those in at the end. All right, what do you think?
So this one I think was a little bit tricky. The answer to this one is actually that head and neck cancer is a risk factor for depression. So we can go on to the next slide here. Older age was the most common answer, and actually for patients with cancer, younger age is a risk factor for developing depression. A prior history of depression is really important to think about for these patients. Uncontrolled physical symptoms, which happens all the time, whether it's pain, shortness of breath, nausea. And then, as this question indicated, the type of cancer or the type of illness is important. So head and neck cancer as well as pancreatic cancer are the types of cancer that are most likely to cause depression in these patients. And then there's certain treatment factors that are important. So if you have a patient who has CNS involvement, who is being treated with steroids or is being treated with either interferon or tamoxifen, there's a significantly higher risk of depression. And also, if we don't think about the holistic approach and this existential or spiritual distress, then there's a much higher risk for depression as well.
I'm going to jump in. This isn't fair because everyone else has to wait till the end for their questions, but why head and neck? Is that associated with communication and the impairment of communication, or do we know with that particular set of cancers?
Yeah, I think that's a great question. I think that there's not clear evidence on what it is. I think that there's probably multiple things. They tend to be the most symptomatic patients, and so uncontrolled symptoms is one of the risk factors, and so difficulty swallowing, difficulty eating, lots of pain. And then I do think that there's both disfiguration and difficulty communicating that makes it much more challenging to manage and increases the risk.
All right, thank you.
Yeah, appreciate it. So despite the fact that it's extremely prevalent, it's very difficult to diagnose, and we often miss the target and have difficulty diagnosing depression. And the reasons for this is that both clinicians and patients struggle to really identify the fact that they're depressed. I think that clinicians get attached to patients, and much like oncologists or clinicians with a primary relationship with a patient tend to overestimate the survival time for patients, I think they tend to underestimate the amount of psychiatric distress that patients are having. And patients oftentimes don't want to talk about it. It can be a sign of weakness or a sign that they're doing something wrong. So in these seriously ill patients who have cancer, there's often that significant diagnostic challenges. There can be very difficult clinical presentations, often very complex differential diagnoses, and lots of comorbidities. And again, I think the attitude of both providers and patients can be a barrier. I think that a lot of times what I've heard in my practice is that it's a normal part of having cancer, it's a normal part of aging, it's a normal part of being sick. I would be depressed too, as our case said. Anyone would be depressed in my condition, and that's not always true. So if we miss it, how can we do a better job of detecting it? And there are two basic ways that we detect depression in cancer or in general, but there are self-report mechanisms and also criterion-based. And so for the self-report mechanisms we use in screening tools, there's the PHQ-2, PHQ-9, all sorts of different scales, but the ones that have been most validated are the Beck Depression Inventory, Hospital Anxiety and Depression Scale, and then the Geriatric Depression Scale. These are all screening tools that are given to patients, and they can respond based on the symptoms they're having. Criterion-based is the gold standard, and that's when a clinician, either a psychiatrist, psychologist, or other mental health professional, does an interview with the patient and uses either the DSM-5 or the research diagnostic criteria to diagnose a person with a psychiatric illness. Having said all that, there's an interesting study that was done back in 1997, and we struggle about how to think about this and how to diagnose these patients, but there were a group of 197 palliative care patients who were in an inpatient palliative care unit with advanced cancer, and they compared 4 different screening tools or mechanisms. There was a single question just asking the patient, are you depressed? There was the PHQ-2, and then 2 others called the Visual Analog Scale or the Beck Depression Inventory Scale. And sort of surprisingly to me, the very simple question that seems basic, asking, are you depressed, was by far the best screening question and the most sensitive and the most specific. So part of me thinks, try not to overthink it, ask the straightforward, simple question, and oftentimes you get the best response. So in terms of the DSM and the criteria for depression, go over the basic definition. You have to have at least 5 symptoms over a 2-week period that represent a change from baseline. You have to have the core symptoms, either one of having a depressed mood or having a loss of interest or pleasure. And then you have to have these other symptoms, and I've highlighted in red the symptoms that are actually somatic in nature, which are extremely common in this cancer population, but having a significant change in appetite or weight changes, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive guilt, diminished concentration, or recurrent thoughts of death or suicidality. So a challenge in this population is that over half of these patients have some of these somatic symptoms from the illness that they're experiencing. So in order to combat that, I think it's helpful for people to know about what's something that's called the Endicott substitutive criteria for patients with advanced cancer. It takes the somatic symptoms that are proposed in the DSM-5 and proposes replacement criteria. So for the symptom of poor appetite or weight gain, the proposed replacement criteria is this more subjective and something that you can observe of fearfulness or depressed appearance in the body or face. Instead of insomnia or hypersomnia, there is this idea of being socially withdrawn or decreased talkativeness, both to family and to clinicians. Instead of the loss of energy or fatigue, There is this, what's described as brooding, or really a loss of optimism and a focus on pessimism and self-pity. And then instead of the cognitive effects of the decreased concentration or slowed thinking, there is this idea that a patient has a lack of reactivity, can't be cheered up, and does not smile at all, and has no response to good news at all or to any sort of funny situations. So key features of depression, there's certain things that are normal. It is normal to, when you get a life-altering diagnosis, whether it's a cancer that can be treated or a cancer that's terminal in nature, the idea of having sadness, having grief, of having anticipatory feelings of losing your own life, of losing relationships, those are things that all are appropriate. The things that stand out in the literature as really not being appropriate and really need to key you into the idea that this person may have a disorder that needs further attention from either medication or therapy are these feelings of guilt, feelings of worthlessness, hopelessness, and helplessness that are really throughout that aren't reactive at all. Social withdrawal, and then any sort of suicidal ideation that's never appropriate even with patients with advanced cancer. So in my world, I think one of the hardest things for me to do, and the hardest thing to do when you're at the bedside, is to differentiate between this grief that's appropriate and that is a normal process that goes away with time versus the depression that really needs further attention and treatment. So I'm going to go through a list of things and do it somewhat quickly, but really highlighting some of the differences between normal grief and depression. So normal grief, it's expected that you connect your depressed feelings very specifically to your loss or your diagnosis. In depression, it becomes much more pervasive. The patients lose their ability to really connect it to a specific idea. In grief, you do have brief periods of being able to respond to comfort or to support. In depression, there's really this lack of response no matter what's happening, no matter what's going on, that there's an inability to respond to these offers. Again, brief periods of joy and happiness in normal grief, even if someone cheerful, difficulty experiencing joy, there are these moments where they can still appreciate things. In depression, the opposite of that with almost no joy. The guilt that we've talked about is over very specific aspects of wishing you'd done something different, wishing you stopped smoking, something like that. Whereas in depression, you can't link it back to one specific thing. Again, this idea of it being all-consuming and pervasive. Self-esteem is another core issue in depression, and this is something that can have a temporary dip, but usually there's a sense of resiliency where patients can bounce back. The low self-esteem, again, you see the word pervasive there is much more generalized in patients with depression. And this idea that, I said suicidal thinking is not ever normal. This idea that I don't care if I die, sort of passive thoughts, or even, this idea that possibly, my quality of life is not worth living, those are reasonable thoughts to have, but significant or frequent thoughts of actual suicide or with an intent or a plan is never something that a patient should have to experience. So when I'm thinking about it, words are really important when you interact with these patients. And so thinking about how you can ask questions in a way to elicit this information from these patients. And some of the things that I've come across that have been most helpful in my clinical practice are asking things like, are there moments you can still feel joy despite the sorrow that you've been through? Something like, what keeps you going on difficult days highlights these moments where they are able to have the resiliency. And then asking, what sources do you draw hope from? Those are some of the examples of questions that have worked in my practice. So we've talked a lot about depression and some of the diagnostic challenges, and some of the issues is that these patients have problems not only with depression, but with cognitive impairment and as well as what's called delirium and fluctuations in their consciousness given how sick they are. And the issues is that they have both shared symptoms and shared risk factors. So in terms of the symptoms, there are patients who have physical illness that causes, that also have mood symptoms and also have cognition. So you can see, the overlap in the center there where there's these patients who have all three, and it's almost impossible to tease out exactly what's going on or what's the primary driver. It also is, they're all risk factors for one another. So if you have a patient who is depressed, then and also a patient who has cognitive impairment, those are high risk factors for developing confusion or delirium, which makes it, again, these diagnostic challenges that when you're at the bedside trying to figure out what's going on with the patient who's not responding to you, who seems confused, who doesn't look like their normal baseline, it can be extremely challenging to tease it out. So, suicide is the scariest thing that can happen to these patients who, the patients who have depression in this population. There's a study that was done, I think it was back in 2008, there was a cross-sectional survey of almost 3,000 patients, and they used the PHQ-9 to assess patients' suicidality. And item number 9 asks the question, it says, over the last 2 weeks, how often have you been bothered by the following problem? Thoughts that you would be better off dead or of hurting yourself in some way. And what they considered was a positive response was at least several days or more frequently. And just as a caveat, I think that in this advanced illness population, this can be challenging because this idea that you might be better off dead could be interpreted that quality of life isn't worth living, and it's something that it doesn't necessarily indicate suicidality. Having said that, it does indicate distress, and what the findings showed is that almost 8% of patients with advanced cancer had some sort of were positive responders to this question. There was significant emotional distress related to that, and there was pain was a risk factor, and then older age was also associated with a positive response. So we know that patients have these thoughts. How many of them actually commit suicide or act on it? And so a separate study, which looked at a large population and adjusted for age, sex, and race, looked at the rates of suicide for patients and showed that it's actually twice as likely for patients with cancer to commit suicide than patients who don't have cancer. And again, the demographics show that the risk factors are that there are higher rates in men who are white, who are older at the time of diagnosis, and then in specific cancers, I mentioned the head and neck, but also lung and bronchus, as well as stomach cancers are high risk. And there's really this finite time period where it's right after diagnosis within the first 3 months, and then that risk carries over to the first 5 years after diagnosis, where there's this increased vulnerability and susceptibility to suicide. So this is a graph that depicts this and shows what the increased risks are. You can see that in looking at the graphs here, you've got the relative risk on the y-axis and then the type of cancer. On the x-axis, you've got patients who don't have any cancer depicted here in the light green, and then patients who do have cancer in purple. You can see that the relative risk, especially in lung, GI, and CNS, is significantly higher than patients who are cancer-free. Head and neck's not included in this. Some of the common symptoms and syndromes that you can have, we've talked a lot about depression, but there are multiple other psychiatric comorbidities that can occur in patients with advanced cancer. It's very common for patients to have fatigue and sleep disorders. Anxiety, panic attacks, and PTSD are quite common. In my practice, I've seen quite a few patients who have been traumatized by either the diagnosis of cancer and the way that news was delivered, whether it was done in a somewhat blunt way that the patient was overwhelmed by, or also through the treatment process, whether it's surgery or chemotherapy, but what the patients view as traumatic experiences that really impact them in a way that develops a post-traumatic stress response and disorder. We already talked about the cognitive impairment and delirium as well as dementia. And then it's really common these patients are on so many medications to have either drug intoxication or withdrawal, both from the opioids that are prescribed or the benzodiazepines that are prescribed, but also from alcohol or other illicit substances that are used to cope in these patients with advanced cancer. And then also pain and functional impairment is a huge issue in this population. So they're not only not only are the patients who have these diagnoses at higher risk for for psychiatric syndromes, the medications that we give these patients can actually cause some of these syndromes. So patients who are treated with steroids, which is extremely common, can cause mood problems, can cause problems with cognition, can actually make patients manic or very agitated when they're in the hospital. Dopamine blocking antiemetics like metoclopramide or compazine can cause akathisia, which is this sense of restlessness or unease, feeling like you have to move. Cisplatin, a common chemotherapy, can cause leukoencephalopathy. Methotrexate, another common medication that you all see, especially when used intrathecal, can cause significant mood symptoms. Tamoxifen has been in the news quite a lot, and there's this question of whether or not it causes depression and whether or not the treatment of depression actually decreases the effectiveness of tamoxifen. And then leuprolide acetate is another one that can cause mood symptoms. And any of the cytokines that are used in treatment, whether it's interferon alpha or interleukin-2, can cause significant depression. So, excuse me. The takeaway from this is really just that these patients are extremely sick, and lots of the medications we use to treat them can cause psychiatric side effects. So let's talk specifically about some of the medications that we use in this population.
All right, so another poll. What percentage of cancer survivors take medications for depression or anxiety? So if you think that's 20%, go ahead and answer A. If you think that's just 5%, B. If you think that's 50%, C. And if you think that's 10%, D. All right, moving around, although it looks like people are picking predominantly the high numbers.
On the higher side.
Just a question of how high.
Right, it's always a guessing game with these numbers, but clearly people are thinking that on the higher side is more likely than less likely.
Sure. Well, while we give them a few more seconds, maybe I'll follow up. You said treatment of depression. There's some literature talking about that decreasing the efficacy of tamoxifen.
Mm-hmm. Yeah, so I actually have a slide on that coming up in a little
bit. Oh, great. Okay. We'll save it for then. So how did they do?
The good guessing in the numbers game. So 20% is correct.
Okay.
We can go to the next slide here.
Great.
So you can see that patients who are survivors of cancer, based on a huge population study that looked at 3,100 patients who had cancer compared to almost 45,000 patients who did not have a diagnosis of cancer. They looked at both anxiety medications, depression medications, or the chance of taking both. And for anxiety medications, sort of down the line, they're twice as likely to take these medications than to not. For anxiety medications, it was 16.8 to 8.6. For depression, 14.1 to 7.8. And then for one or both, it's up to that 20% number of cancer patients who are survivors versus only 10% of the general population. And from a strictly numbers standpoint, that means that there are 2.5 million survivors of cancer who are on some sort of psychiatric medication for treating either depression or anxiety. And again, it's always helpful for me to think about these predictors, and it seems like it changes based on the population or the individual studies. But for this population, predictors of taking medications were being younger, less than 65 years of age, being white, being a woman, and then this idea of chronic medical comorbidities resurfaces again. So if you have more than 3 medical comorbidities, makes you much more likely to have depression. What I found interesting is this is an access issue. It doesn't really talk to the actual epidemiology of risk factors, but patients who are insured have more access to medications and therefore were more likely to be taking these medications. So let's talk about the antidepressants and which ones are used in the treatment of cancer. There was a 2015 Cochrane review looking at a meta-analysis, looking at 9 different studies. 7 of those were meta-analyses, and they compared antidepressants to placebo, looking at whether or not certain types of antidepressants were more helpful than others, whether they were efficacious or not, and maybe embarrassed is the wrong word, but somewhat, I think, kind of as happens in psychiatry, reporting that there really was not a conclusion about how effective these medications are. In my mind, because of a lack of high-quality evidence, but what the conclusion said is that available studies were few and far between and were very low quality, that there was no clear evidence of an effect for antidepressants, and that clear implications for practice cannot be made. Having said that, what I tell people is that treating patients with antidepressants, we know that it works in other populations, although the success rate is somewhat lower, and the risk of using these medications is fairly low, that I certainly in my practice have found it quite beneficial and quite useful. But it's interesting to note that the studies out there have not always confirmed that, or have not confirmed the effectiveness. So we'll do a brief, try not to be too thorough, but a psychopharmacology lecture. I know this is supposed to be for non-prescribers, but I think it's helpful to think about the mechanism of actions for these medications. So going through this, there are several different types of mechanisms. There are the monoamine reuptake inhibitors, and so the monoamines are either serotonin, norepinephrine, or dopamine. So you've got the serotonin and norepinephrine reuptake inhibitors, and those are the ones circled here that are amitriptyline, which is actually a TCA, but then venlafaxine and duloxetine, which are SNRIs, which fall into that category. We have the serotonin reuptake inhibitors, and we'll go over those again, but that's sertraline, citalopram, paroxetine, and fluoxetine. There's the dopamine medications, and that's bupropion. And then there's another class of medications that don't act on the monoamine reuptake inhibitors, but actually work as psychostimulants, and those are medications like, people know Adderall, but dextroamphetamine, methylphenidate, and modafinil. And then there are these, the novel antidepressants such as trazodone and mirtazapine that work in non-traditional ways. So again, the SSRIs are the most common medications that we use in cancer, just in psychiatry in general. I think it's helpful to note that there are both, and it's always confusing to me and to patients, but they're with all medications, both the generic name and the brand name, so helpful to know both of those. I've highlighted in red here the ones that are most commonly used, and the reasons for that are that in general, Zoloft, Celexa, and Lexapro have fewer drug-drug interactions than the other SSRIs. So what are the common adverse effects from using SSRIs? So what's been reported in the literature and what patients say is that nausea and diarrhea, an initial sense of anxiety or nervousness, so when you first start taking the medication, that it can exacerbate the sense of restlessness, headaches, sexual dysfunction is a major one, and then sleep disturbance as well. And that for all of these, actually, except for the sexual dysfunction, tends to last longer, but for the other ones, this is something that occurs early on, and usually within 3 days, certainly within a week, they tend to go away. So I really encourage patients and people to stay on them at least through that first week to see if the side effects go away. So this is an interesting chart that talks about the sleep disturbances for SSRIs, and for each of the different ones, what's interesting to me is that people respond so differently to individual medications. So there's both insomnia or hypersomnia, and anywhere over 10% for each of the medications have either insomnia or hypersomnia. So you can't really predict how a person's going to react, but asking about sleep is definitely an important part of the assessment. So the novel antidepressants that I mentioned in the brief chart initially are bupropion or Wellbutrin, which is I mentioned is a dopamine medication. That is the most activating or energizing medication of the antidepressants. The issue is that it can decrease the seizure threshold, and so in a lot of these patients who have cancer, it can be a concerning medication to use because of oftentimes the risk of CNS involvement or of seizures. Trazodone is a good medication for sleep. Again, the ones I've highlighted in red, mirtazapine or Remeron is a great medication. It is one of the more sedating medications, can be used at night, avoids the symptoms of nausea and feeling like you're nauseated, and actually can stimulate appetite, and then Effexor is a medication that can be used. It's helpful because it also, as an SNRI, can help with neuropathic pain. So it has the effect of treating anxiety and depression, but also helping with the pain that often overlaps in these patients. And then Cymbalta is the same as Effexor. Again, so using the brand names Remeron, Effexor, and Cymbalta are the novel antidepressants that are most common and effective in this population. So here's a very busy chart. Hopefully you can see it from there, and I'll just go over it briefly, but I think it helps highlight some of the things that you need to watch out for with these medications. So in thinking about whether or not you need to reduce the dose in renal disease for paroxetine or Paxil, duloxetine, and mirtazapine, you really do have to decrease it in renal disease. Other ones, often not as much. For liver disease, there's almost all of them have to be reduced, and you can see there that Cymbalta actually is contraindicated and is one that you would not use. And then whether or not in the elderly patients, again, the rule is sort of start low and go slow, trying to use lower doses of these medications. I would not avoid them, but just trying to use lower doses. And then the last column here talks about drug-drug interactions. And again, patients who are on chemotherapy, thinking about these drug-drug interactions, multiple other medications, this is really the go-to thing for me. So sertraline or Zoloft, citalopram or Celexa, or escitalopram or Lexapro are the best medications. So the psychostimulants that I mentioned are Ritalin, Dexedrine, Cylert, or Provigil. And I really like these medications because in the population that I work with, the antidepressants often take up to 4 to 6 weeks, sometimes 8 weeks to take effect. And patients with advanced cancer, especially those who I'm seeing towards the end of life, we may not have that much time in order to have an effect for the depression. So these stimulants start to work within a day or two, can really help with patients who have significant problems with amotivation and fatigue, as well as cognitive symptoms. And so this is one of the more common medications I use, and you'll often see in patients with depression. The side effects can be that they can infrequently cause some decreased appetite and can also be abused, but generally in this population, not as worried about that. But if there are red flags, it's something to be careful of. So the anxiolytics are a class of medications that are used very frequently in this group. Just to go over the ones that are used, Valium is one of the benzodiazepines that's very common. Where that's seen most often is in the COA protocol or in detoxification for patients who have alcohol use disorder. It has a very long half-life and has lots of active metabolites, so is not a medication I like to use in this population. Ativan is one of the ones that's used more frequently, and I do like. It has a favorable drug interaction profile, and it also can be given in patients who have liver failure, and so it's one that often is used more frequently. Also can be given in multiple routes of administration and has a somewhat shorter half-life, so wears off over a brief period of time. Klonopin is the longer-acting one, and it has a much lower chance for abuse or misuse, and I like this as a bridge to treat anxiety in order to give time for the antidepressants to take effect. And then Xanax, you can see down there at the bottom, we've sort of become I saw an article saying, we're the Prozac Society that's now becomes the Xanax Society. It's really one that I try not to use at all in my practice. Extremely short-acting, can work to get rid of a panic attack, but patients often get a high from it. The risk of abuse is incredibly high, and so it's one that I don't use in this population or others. So the atypical antipsychotics can be really useful in this group. The ones that are seen most frequently are quetiapine or Seroquel, and this is a good one because at low doses it's very sedating and can be used for sleep, and and at higher doses it has its antipsychotic effect, but it has less of the EPS side effects, which are the extrapyramidal side effects, which can be dystonias, or it can be what's called NMS or neuromalignant syndrome. Risperdal is another medication that can be used. And then Zyprexa is one that is quite frequent in my practice. It helps with both nausea and with sleep, and also can help with appetite and weight gain. So Geodon I try to avoid because of the risk of QTC prolongation. And then Abilify is another one that can be helpful, but often can activate or be difficult for patients to tolerate. So we'll wrap up with just a few of the drug interactions that happen. I mentioned the QTC prolongation. Methadone is a medication for pain that is used in this population, and methadone has significant risk of prolonging QTC, as do a lot of the cancer chemotherapies. So being aware that patients who take methadone are at risk for heart arrhythmias. Any sort of antifungal agents can have an effect on the CYP3A inhibitors, which can affect the way that other medications are metabolized. There have been case reports, which is really interesting to read up on, of irinotecan and any of the SSRIs causing near-fatal rhabdomyolysis, which is breakdown of muscle tissues leading to renal failure and altered mental status. And then procarbazine being another medication that actually has the mechanism of action similar to an MAOI. So when combining that with SSRI, can lead to what's called serotonin syndrome, causing agitation and altered mental status in these patients. And this is getting back to what you mentioned with the tamoxifen and the 2D6 inhibition. We can move forward and talk about that. So tamoxifen, there is used to treat patients with breast cancer, and it's processed through 2D6. And so many of the antidepressants have an effect on the CYP2D6 metabolite. And so this chart shows that for patients who are on tamoxifen, that using medications like venlafaxine or mirtazapine that have minimal to no inhibition of the CYP2D6 are the safest choice to use in patients who are on tamoxifen. And then it goes in order of escalating risk for altering CYP metabolism. And so there was this thought, I think this came out several years ago, and there was a concern that if you were taking, that tamoxifen causes depression, and if you're taking a medication to treat the depression, that it may decrease the effectiveness of tamoxifen. But there was a large study that came out that actually looked at this, and it was a follow-up over 14 years for almost 17,000 breast cancer patients, and it showed that 50% of them were treated with an antidepressant, showing how prevalent these symptoms are. But there actually was not increased risk of subsequent breast cancer, so showing that it did still maintain its effectiveness. So just wrapping up now with the case that we had started with at the beginning. Again, remember Ms. F is a 78-year-old woman who has metastatic breast cancer to the bones and liver. And so the things that stand out for me in this case that shows that she is depressed is that this idea that she recently stated that she no longer wants treatment. When you're assessing someone's values and what's important to them, it's been highlighted that she wanted to live and that she wanted to continue to be there for her daughter. And so this abrupt change in treatment desire can be an indication that there's something deeper going on than poor quality of life. Uncontrolled pain is a big risk factor. No interest in hobbies, or this idea that there is no reactivity and not able to enjoy the things you typically used to enjoy. And then this idea that it's normal, that anyone would be depressed in my circumstance, is not something that that is normal for patients to say. So, in wrapping up, I just appreciate you guys listening here. I think this is obviously a passion of mine, and what I think I'd like people to take away is that psychiatric illness is extremely common for patients with cancer and is often under-recognized. These medications are extremely common in the cancer population and have frequent interactions with other medications that these patients are taking. And all of the providers that are caring for these patients should be aware of common psychiatric illness and the medications that are used to treat these patients. For me as a physician, I often see patients at snapshots in time, and so I rely wholly on nurses who are there at the bedside, who have more frequent interactions, who can establish a patient's baseline. So not expecting to know how to titrate medications or how they work, but be able to recognize that they're on this medication, that something is different and there's something abnormal, and then be able to report that back so that as a team we can think about how to improve the quality of life of these patients who have these psychiatric symptoms. So at this point, I'd be happy to take any questions or have a little bit of a discussion.
Great. Well, we'll look for those questions. Again, if you did not already initiate the Poll Everywhere piece, just text the letters UNCCN to the number 22333 to get that join response. If you've already done that, then you're in, and we'll look for your questions right now, and we'll go ahead and put this up. So I thought this notion of these three pieces that really seem to work together almost like a three-legged stool, the mood, the cognition, the physical illness, was very interesting. And at one point I perked up because you were talking about using psychostimulants, and you listed Ritalin as one of those. And certainly when we've talked about chemobrain and the ways to, some of the same strategies that are used for people with ADD or ADHD are used for people with chemobrain, and I would imagine that you get these kind of interesting interactions where you're treating somebody for depression, but at the same time providing a medication that helps to minimize the effects of chemobrain, in turn maybe lessening some of the depression caused by the better cognitive functioning. So tell me more about that and how we can treat all three of these and how they interact with one another to improve the life of the patient.
Yeah, I mean, I think you described that very well, sort of the complicated process that occurs and the cycle that occurs for these patients who are chronically ill, medically ill, receiving chemotherapy that affects cognition. And so I think that the nice thing about methylphenidate or about a stimulant is that sometimes we can't totally, by interview, establish or diagnose exactly what's going on with these patients. We can't put a label to it. We can't definitely say this is depression, but we recognize that they have this fatigue, they have this frailty, they have this difficulty with concentration that may or may not be a part of either their cancer or their treatment. There's multiple different reasons for them to have that.
Sure.
But the use of a psychostimulant has been shown to really address all of those, to help with motivation, to help with the concentration, and to help with the symptoms that are very common in that population.
Okay, good. Thank you. And we've got our first question in from our audience. How do you dose the methylphenidate in cancer patients, and do you?
Great question. Yeah, I use it quite frequently, and I think some of it depends on the preferences. When I'm working with patients, I like to be a doctor and give them a recommendation, but I also, if they're worried about side effects and want to start low, then to be aware of that. I think the key thing is that it's dosed twice a day, so it's given at 8 a.m. or around breakfast, and then the other dose is given at noon, because what it does is it gives you energy, and so you don't want it to interrupt sleep. So if you give it later than noon, then it can cause sleep disruption. So typically the starting dose I use is 5 milligrams one time in the morning at 8 o'clock. Make sure they tolerate that throughout the day. And then we'll go to 5 milligrams twice a day at 8 a.m. and at noon. See if they tolerate that. And then every 2 to 3 days, you can increase it actually up to a dose of up to 20 milligrams twice a day.
All right, thank you. We'll hopefully get some more questions. I jotted down a few others. So we've had some different clinicians come in and talk about patient-reported outcomes. Dr. Bosch has been here and talked about that. And as you were talking about the different symptoms that patients are experiencing around depression, is work being done incorporating that as a part of patient-reported outcomes and then being able to address those systematically as and hopefully more regularly as they occur? I don't know what kinds of conversations are being had around that.
Yeah, you mean specifically in the cancer population?
It's specifically in the cancer population. With having Dr. Bosch here, it was interesting to have him talk about how they're able to see greater efficacy in treatment because of getting these more regular reports from their patients, sometimes using an app or something like that, and also maybe overcoming some of the barriers. Maybe a patient, he or she might be more reluctant to report certain symptoms for a variety of reasons, including that they don't want their provider to feel ineffective or other things. So I don't know if to what degree reporting on and then addressing depression issues is a part of that work yet.
So yeah, I mean, I found it fascinating talking to Dr. Bosch about that, and it was that the statement he made that this basically just using patient-reported outcomes to increase access, that the effectiveness of that in terms of increasing survival was the same as trying to all the research money that goes into creating a new chemotherapy drug that costs like one billionth of the money. But I do think that depression screening is a part of that, and I think that there's an ongoing push to standardized depression screening, whether it's the PHQ-2 or the PHQ-9, to increase access to patients so that you're checking in more frequently, whether it's weekly or every other week, and then to take that information and to act on it. One of the issues is that collaborative care is a big thing in the psychiatry world, and it's in primary care, but trying to leverage the psychiatric expertise because there are not enough providers to do all of the work for the demand for patients who have psychiatric illness. So figuring out ways to triage and access patients to report their symptoms, to have nurse practitioners or nurses be able to feel comfortable making recommendations, or primary care doctors, and then based on whether or not symptoms are improving over time on these standardized measures, be able to then shift them to psychiatrists who can see them in direct clinical interactions.
Gotcha. Okay, thank you. We've got a few other questions here. Are there any drug interactions between SSRIs and methylphenidate?
No, nothing I don't worry about. The main thing that I worry about with methylphenidate is that it can cause somewhat increased blood pressure. So venlafaxine is an SNRI, but that can cause increased blood pressure. So worry about tracking that when using those two together. Wellbutrin is another medication that is a more activating antidepressant, and so using Wellbutrin and methylphenidate together, worry about worsening anxiety and restlessness just because of the overuse of the stimulant effect. But there are not significant drug interactions between methylphenidate and SSRIs.
Okay, thank you. And which class of antidepressants do you use if anxiety is greater than depression?
Good. So there's the way that I do my decision making for which medications to choose. As you saw in that Cochrane review, there's not clear evidence that one works better than the other, but the SSRIs are the gold standard for treatment of anxiety. Anecdotally, and from talking to patients, I have felt like patients who have more anxiety than depression, that Lexapro or Zoloft tend to help more with those patients. And then if they're really having anxiety and racing thoughts that are keeping them from sleeping, mirtazapine or Remeron is one I like to use. First of all, because the sedative effect actually takes effect right away, and so if a patient really feels like they need something, they can't wait a week or two for medication to start working, they'll notice that they're sleepier and they're taking that medication. It can tamp down some of that sort of adrenergic, on-edge effect of anxiety. So either Zoloft or Lexapro for standard anxiety, or mirtazapine if there's a significant insomnia component to it.
All right, thank you. Well, we've got just a few other things I want to mention. I do want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund, also known as UCRF, and of the UNC Lineberger Comprehensive Cancer Center for their support for this program. Also, Mary King, Veneranda Obore, and Alan Brown for all the hard work that they do to make this and each one of our presentations possible. I want to mention that we've got some lectures coming up on October 25th at noon. We have a Med-Surg lecture, The Role of Radiation Therapy in Advanced and Metastatic Disease, with Dr. Perlstein. On October 22nd, Community Lunch and Learn lecture, an update on breast cancer prevention, treatment, and survivorship with Dr. Anders. And on November 8th, RN and Allied Health lecture, the role of palliative care and hospice care in improving quality of life with Dr. Winselberg. So we'll look forward to all three of those and hopefully having you here for those. We also have a special lecture coming up, and in addition to the other types of continuing education credit, this also has a a dental component with it, and we're very excited to have this special lecture, Oral Cancer, a Comprehensive Overview, on Friday, December 8th at noon, and this will include Drs. Patel, Dr. Hackman, and Dr. Padilla. You can find information about this, and again, that includes an ABA dental continuing education credit in addition to the CNE, CME, and ASRT credits. So we hope you'll help us spread the word on that. All right. Thank you for being here today. Let us know if you have any feedback for us. Be sure to do your evaluations if you're getting continuing education credit, and be sure to check us out on the web for a variety of things, including a recording of this lecture, and then as we move to our new learning management system and our enduring materials, this will be available for credit anytime within the next year. Not available quite yet, but you can look for that in the coming weeks ahead. All right. Thank you all so much. Thank you so much for being here and for this great presentation.
Yeah, thanks for having me. It's a wonderful service, and look forward to hopefully being involved more in the future.
Good. We would appreciate that. Thank you.